So 145, 315. Well, why don't we get started, and then in case they will step in wherever they want. So let me see around. We have a pediatrician, dentist, emergency medicine, surgeon, internal medicine, family medicine, and internal medicine again. Okay. This unit is about prognosis. What's your best definition of prognosis? What is prognosis about?
Future outcomes.
Future outcomes. Even treatment is about future outcomes, right? So what specifically are we interested in prognosis?
Morbidity and mortality.
Morbidity and mortality. So what is the history of a disease? What will happen to a patient if untreated? Or even what happened to the patient receiving the best treatment. But anyways, what we can anticipate will happen later on. So in a way, it's similar to diagnosis. Based on patient characteristics, we decide if a disease is there or not. But in diagnosis, we look at present. There's a symptom now, there's a disease now. There's a positive test now, there's a disease now. In prognosis, we look at patient characteristics at present time, and we are interested in what will happen later on. So there is a time dimension to prognosis. That's the main difference between prognosis and diagnosis. In diagnosis, we are interested in dividing positive and negative, those with diabetes, those without. In prognosis, we are more interested, once we know who has diabetes and who has not, what will happen over time to those patients. And it's a pretty common question, the one we get about what next, what will happen now. There are a lot of studies trying to answer question about prognosis. Now, for this specific unit, we will look at the paper and we'll try to assess if that was good, if it helped us answering the question, exactly like you did with treatment, with harm, and with the systematic review earlier this morning on using or not antibiotics. In this case, it's particularly important to read the clinical scenario. So before we move to answer the question, let's take a few minutes to read again over the clinical case. Anyone that can help in summarizing or reading over this case? What's the problem? What's the disease? So the patient has a chronic condition, rheumatoid arthritis, and she's on treatment with chronic prednisone for about 6 years. And she came to the hospital with chest pain, retrosternal chest pain, going up to the shoulder, and she woke up with that. And when assessed in eMERGE, it looks like those symptoms are there for 2 weeks. So is a coronary syndrome likely? Yeah, it might be. Usually 2 weeks is quite a safe coronary syndrome for you. If it is going on for 2 weeks, it's likely not an acute devastating MI, but can still be coronary syndrome. You ask, of course, about rheumatoid arthritis, and it looks like she's in a stable phase. She doesn't report any previous illness. Why are you interested in recent diseases?
Active disease?
No, I mean no recent flare of rheumatoid arthritis nor any other previous illness. Is that important information? Yeah? Why?
You are talking about pericarditis.
Yeah, so pericarditis may follow a viral infection or may be part of a flare of rheumatoid arthritis. Chest pain is not positional. Is this important? Yeah, why?
Again, pericarditis.
Pericarditis is positional or not? Is positional. In particularly, is relieved if you lean forward this way. So in this case, we would have expected being positional. What's another retrosternal pain that is positional? GERD, acid reflux. Usually it doesn't happen or is less burning if you sit up, while if you lay down it may be worsened. Okay, so some help there. Then you do the exam, she has no fever, blood pressure is normal, heart rate is normal. There are crackles all over. No cardiac murmur, no rub, no evidence of any synovitis. So no cardiac rub, no murmur. Does that rule out pericarditis? No. Would have been nice to have a rub, but it's not there. Oops. Of course, you try nitro, no response, partial response. What about the EKG? Are you worried about that?
Yes.
Okay. So everyone is worried, and she got a cath lab. That was negative. Later on, the ST elevation is now diffuse on all lead. And also on echo, a small pericardial effusion appears. So it looks like, yeah, it's getting to pericarditis. Better pain relief with ibuprofen. Is that typical of pericarditis? Yeah, I mean every pain responds to ibuprofen, but at this point coronary are negative, so what else can be? For sure the GERD pain doesn't respond to ibuprofen in case it goes worst. So she's transferred now out of the ICU and get to the medical ward. And she tells that she's not clear if this is rheumatoid arthritis or something else. And there is no evidence of infection around her heart, which is okay. That's what you tell her. What you get back is that she heard about pericarditis. And she also tells you that the pain was really bad. And so her question is, okay, will this come back? And she's worried about these. She didn't know that the heart was closed in a sac, and now this sac is inflamed, and she says, what's going to happen to me? I'm going to die. Everyone is in the end, of course, but she want to know if she will be dying next week. What your answer would be? Will she die of pericarditis? She might. How likely is for her to die?
1%.
1%. That for you is low, for her, who knows? We have to ask. So 99% she will survive. What about the chest pain? Can the pain come back like it was yesterday?
Yes.
Yes. How likely that is?
Maybe 30%.
About 30%. So 1 in 3 will have that pain again. Okay. So if we are sure that this is the likely prognosis of the case, that's okay. We just give this information and that's the end of it. If we are not sure, or if we want to check if what we recall is correct, then we need a paper about prognosis, which we find. So we go to UpToDate, and we find that overall prognosis is good. So no one dies, or no more than 1%. Constrictive pericarditis may occur in about 1%. Now, what is constrictive pericarditis? It's fibrosis, so it becomes a stiff sac, and the heart start having problem contracting. It's not yet death, but you are going that way. No recent reference, and you don't find really anything about the chance of recurrence. So you consult Dynamed, and Dynamed gives you information about recurrence, so does a bit better job than UpToDate, but it tells you that recurrence has been reported in 8 to 80%. Is that useful? No. It's like saying, I have no idea. May recur in everyone, or may recur only in 1 in 10. So maybe he's right, it's 30%. 30% for sure is in the trench. Everything is in the trench. So if you are not right, for sure you're not wrong, because it may be in there. But maybe we can find something better. Why you expect there is an 8 to 80%? What's the most likely cause for such a high variability?
Different etiologies, different samples.
Different samples, different etiologies, size of the study. But most likely, if it's size of the study, well, it's difficult. We would go with the largest one, but very likely the UpToDate, the Dynamed people would have said is 8 to 80, in the larger study is 30. But they didn't say that, so it's more likely that these patient characteristics, different etiology. So maybe if we go beyond the summary level, we read the evidence ourselves, we might find what's the rate of recurrence for, this is not a standard patient, she has rheumatoid arthritis, so maybe we find something about recurrence in rheumatoid arthritis, and that might be better information for that patient, right? Okay, so we search PubMed using the clinical queries. Did you have your lunch search session? Yeah, so did you use the clinical queries? Okay, so you go in, you put down pericarditis, you select the clinical queries, narrow scope, so you're sure that you get just stuff that is relevant to you for the prognosis tab, and you get indeed 200. Now if you do it today, maybe you even get 300s. Around the 20th, you find a abstract reporting about 400 patients followed for 3 years. And you decide, okay, let's have a look at this one. And that's the that's the paper that you have to assess. Now we have a set of questions, like for any other, and this question comes from the user guide to the medical literature. And so my proposal is that one of you reads the question and the other in turns answer the question, so that I can rest. No, I mean, I will help you and I will answer with you, but at least we force ourselves to a working group. If not, you will be asleep in a few minutes. So who wanna read the question? That's the easier part. So yes, she volunteered, good. Pediatrician, quick. Good. So you read the question, and then in turn you answer the question. And then you start answering, then we answer all together. So what's the first question?
Was the sample of patients representative?
Okay, and have you read the paper? No. So do you want to take, say, well, we may take a minute for each question instead that spending time all at the beginning. So where do you think you'll find the answer to this question? Methods, or, yeah, methods, patient selection, inclusion criteria, and then also the first paragraph of result where the patient are described. So what does the paper say about this one here? Everyone has the paper accessible? I have a copy if someone needs a, you need a printed copy? Okay. Oop. Ecco. So, how are these patients described in the paper? How did they got their patient? What's their recruitment strategy? Is this prospective, retrospective? Prospective. So, where was the study done? Italy? 3 centers. Okay. Are these, which kind of centers are these? Pericardial disease. So, very highly specialized center. Is that good or bad? Why?
In terms of evidence, it's good evidence, but in terms of applying, it might be not applicable to our results.
Okay, so this might not be standard street patient that walk in into emerge. They might be patient that surpass the first assessment and are referred to. So they might be more severe than the one you see. Okay, what do you think of the patient we saw in emerge? Is that a standard patient, or is a patient that might be referred to a center or not? Yeah, what do you think? He might. I mean, she has rheumatoid arthritis, she's immunosuppressed. So, okay. So 3 tertiary centers. And how did they select the patients?
All patients with cardiomyopathy symptoms.
All patient. So we call this consecutive patient. Is this good or bad? It's good. Why is good?
Larger sample size will give us a good sample.
Larger sample size, but also?
Very
Included
good.
other diseases with inflammatory, pericardial inflammatory syndrome.
Inclusion criteria will be also wide.
Increase the criteria.
So, yeah, criteria are wide. And also, you would expect by enrolling everyone, selection bias is more or less likely? Less, because it's not that you decide the one that you think will do better or will do worse. You take in everyone. It's very important in prognostic studies to include everyone. So this is a good point. There's another point that is very important in prognosis. So they included all those coming with what?
Pericardial inflammatory syndrome.
Pericardial. Do they say needed to be a first episode, could be a second episode? Okay. Recent episode, old episode? No. So if they had said all cases of first occurrence of pericarditis no longer than 7 days ago, you would have been happier or less happy? If they had defined their population by all those at the beginning of the disease, very first evidence of disease, what do you think? Would have been better or worse? Better. Would have been better because you want the population to be inclusive, to be all those feeling. But if this was, say, diabetes, and you were answering the question how often is to get to amputation and how long it takes. Of course, if you enroll patient day 1 of their diabetes or 20 years into the disease, the chance of having a complication is very different. So these are the only 2 criteria in patient selection for prognosis. All patient qualifying, so do not select, and possibly initial common stage in the disease. Particularly for cancer, for cardiovascular, is very important. So on one we are happy. On the other one, they seems not having thought of this aspect. Okay. Male, females, age. Are we happy with those?
They subdivide. So they did the study and subdivided patients. These patients had second episode.
Okay.
The likelihood of
That's fine. If they do subgroups, that's okay. So you would look at the one that is close to the patient you have. Yes, okay, that's fine. Any other observation that may be useful? Let's see what we have on the slide. Consecutive patient, acute episodes. Now, acute episode at least seems to say they were having the disease right away, not coming there for follow-up and having had the pericarditis 2 years back. But still, they could have done better. And then there is some reasoning about referral. We had covered that. Multi-center consecutive is likely to be representative. Of course, you expect possibly complicated patient. Okay, are you happy with this question? Does it help you understanding better the paper? Okay, what's the following question? What is this question asking?
Table 1.
Table 1, yes. So table 1 is always there for randomized controlled trial. Sometimes it's there also for prognosis trial. Do we have a table 1 in this study? Yes, and what does it tell us? Is comparing treated and untreated? No.
Pericarditis, pericarditis.
Okay, so they have created different groups. And which one is the one that we look at? Pericarditis. So we can forget about the 2 other groups because we have a patient with pericarditis. So what does it mean where patient homogeneous with respect to prognosis risk? It's a difficult question because it asks you, is this population, yeah, so is it a population or is it a mix of everything? It's a mix of everything, but what so if you read through the table, male, there's a proportion, some had fever, some had chest pain, but if you look at the numbers, 97% have chest pain, 70% have recent fever, 25 have the pericardial rub, but that's okay. We know that 1 in 4 has that. Half of them ECG changes. Very few had ventricular arrhythmia. About 3/4 have diffusion. So indeed, it's quite homogeneous because the main characteristics, so the effusion, the ECG changes, the chest pain, everyone has. So in reality, white blood cell elevation, in reality, the table tells you that the population is homogeneous. because the important characteristics almost everyone has. You would have been more worried if each of these was present in 1/3, 1/4 of the population. Then was really a mix of everything. Okay, so let's see what yeah, more or less the reasoning, the proposed reasoning is more or less what we were saying. They did the subgroup. We are interested in one specific subgroup, so we look at that one. They say that, well, we would have liked to see severe versus mild case. How you define severe and mild in pericarditis, it's difficult to tell. So I'm not really surprised that they didn't do. I'm happy to see that the main symptoms are present in a large population. Then regarding co-intervention, so co-intervention is an important problem. It's not in table 1. I think co-intervention is table 2. So you may say, well, these patients were all treated, so we are not really looking at the natural history. On the other hand, your patient is treated as well. If you have a diagnosis of pericarditis, you get aspirin and you get ibuprofen. So still answered your question, because you are a patient with that treatment and you are interested in knowing what happened to you. And what's the proportion of treated patients in the cohort? How many got aspirin? 94, so almost everyone. And how many got prednisone is a very minority, corticosteroids 5%, so maybe they had contraindication to aspirin. What about colchicine? Do you use colchicine for pericarditis here? No. So, yeah, I think that yes, and is more used in North America. So they say that they are worried that there's only a few of them that get colchicine, but they are worried because they are in North America. In Kuwait and in Italy, we are okay because we don't use colchicine. So we are happy to see what happened without. Of course, treatment may impact on prognosis, but again, we are speaking of prognosis of a treated patient. So I would say I'm happy with the information. Do you consider this population sufficiently homogeneous for your task? I would say so. So what's the next question then? Follow-up. So was follow-up complete? Where do you find information about follow-up? In results, yes. Doesn't discuss any follow-up. That's no good. So we don't know how many patients they were able to follow.
Table 3 follow-up.
Table 3. So first of all, how long did they follow this patient?
6 months.
And how often? So they saw them at the end, or they saw them during the study? That's possibly in methods. Let's see. Clinical follow-up. They did a treadmill at 6 months for those. Okay.
Yeah, it was 1, 6, and
1, 6, and 12. Okay, that's reasonable, I would say. For a patient like this, you may want to see the patient at 1 month and then a couple of times per year. So, sounds reasonable to me. Do they say how many they were able to see at those times? No. Are you worried? Or let's say, would you have been happy to know we started with 346 and we saw 330 at 1 month, 320 at 6 months, and I don't know, 250 at 12? Would have been better to know. Yeah. So why you think they don't say?
Because they lost a lot of power.
Yeah, maybe they lost a lot. Are you sure that they don't say it anywhere?
No,
Where do they say?
they don't say it.
They don't say, but look at figure 3. Figure 3, where you have the Kaplan-Meier curves. If you look at bottom, there is the number of patients at risk. So ideally, after 12 months, if you read below 12, of the 346, they have 234. Of the 114, they had 94. On the 26, they have 34. Now, it may be that they just knew the events and did some subtraction, but if I read that figure by assuming if the number are those that they assessed, I would say that some follow-up was there. Not everyone, but many were assessed. So again, was reasonably complete. What can happen? If the patient does not show up for follow-up, would you expect a high chance that the patient has died? In this case, pericarditis, we expect a high mortality. No. Do we expect that the patient with a recurrent chest pain is not showing up? No. So in this specific case, those not showing up, very likely, are good. Yeah. Because it's not a deadly disease, and if it recurs, you are in trouble and you'll go back and you ask for care. So was sufficiently complete? Well, to our scope, which is knowing how likely is to recur, I would say so. And these were 3 referral centers. So for this aspect is good, because if there was a recurrence, they would have likely been sent to this center. Let's see what our guidance tells us. They say don't know. It is not clearly stated. I would respectfully disagree. To me, what is in the legend of the table is enough to state how many they were following. And they say that's they say it seems to be there, but it's not clear how many enrolled later. Well, if you enroll late, that's not true. If you enroll later in the Kaplan-Meier, you do not appear halfway, you appear in the beginning. The Kaplan-Meier starts at the beginning for everyone. Even if you are enrolled after 12 months, in the Kaplan-Meier, everyone is moved to start at the same time. So that's not correct. Usually, Kaplan-Meier numbers are, you can use them to measure follow-up. Anyways, 234, 143, 98. It's not everyone, but making the consideration we made should be okay. What's the next question? Oh, any comment on this? Any further comment? How did they measure the outcome? Death, easy. They don't breathe, don't speak. Stay quiet on the floor or in the bed, that's fine. But for recurrence, how did they measure the recurrence? Yeah, you have to check. I have to check as well, I don't recall.
I think they did some investigations.
They did some investigation.
Blood chemistry,
Okay.
Redmond test.
But what would be your outcome of interest here? recurrence. So pain. They just say relapses. And so assuming they are not clear, do you see any good reason to imagine that they use for recurrence different diagnostic criteria than they use for inclusion? Very likely not. So we were satisfied with the criteria for inclusion, and I would imagine that for pericarditis they will have used the same. Patient comes back, has chest pain, they would do the same workup. And they did a pretty extensive workup, was clinical, they had a CMR, troponin, EKG. So they did a coronary assessment for those having differential diagnosis. I would say that it's reasonably acceptable. Anything that I'm missing or we are missing? Anything more in the... They did echocardiogram for quantifying the tamponade, even histology, and very likely during follow-up they did the same. What about adverse event? How they recorded adverse events? Arrhythmias?
All adverse events were recorded, including account pain, relapses, cardiac tamponade, constructive pericarditis, residual LV dysfunction, heart failure, and overall and cardiovascular.
Seems okay to me. Okay, let's see. So standardized protocol, follow-up visits, annual assessment. And yeah, they say the same. So for coding recurrent pericarditis, presumably they use the same criteria as at initial enrollment, which makes sense. Sometimes if you were to follow clinical epidemiology too strictly, you would write 70 pages papers just by continuously saying what you did. But for a clinician, it's pretty obvious. They describe the diagnosis of pericarditis, relapses will be using the same criteria. Would have been nice to have a sentence saying, we use the same criteria for measuring recurrences, but why they should have used different criteria? Makes no sense. So they say it's not clarified how they adjudicated disagreements. What do you think happened? I mean, we're clinical centers doing clinical studies. Possibly they discussed the patient together and then they decided in a clinical round if that was pericarditis or not. So again, it's not described, but it's very likely. It's not a perfect paper. There are some missing information. In the field of prognosis, many papers are like this because there is less clear guidance. There is no PRISMA statement. There are no specific guidelines about how to. Also, when you ask for ethical approval for a study like this, you not necessarily have a CRF very well defined and standardized, so you are less forced to do good research. Do you share this doubt? First of all, what is this guidance suggesting? It says it's not clear if the Kaplan-Meier analysis includes only patient at each reassessment interval, or if this pool includes patients who recovered from a prior recurrence and their second or third bout was also included. So that's right. They don't say if only the first episode was considered and then the patient was excluded, or instead the patient was kept in. You would imagine that when the patient has a recurrence is off the study, because they don't speak of second, third recurrence. And this is what is suggested there, but say, well, but I'm not sure, because 32% recurrence feels high. What does it mean, feels high? I mean, to us, feels good. That's what he said in the beginning. So I strongly disagree with that last sentence. You can't say, I don't know what they did. To me, this result do not match my practice. Well, if you know already the result, don't go and read the paper. If you don't, well, whatever comes up, comes up. So this is another sort of bias that you should not have. And 8 to 80, 32 is right in between, actually is on the low end. So I might say that 32 to me feels low, not high. So that last sentence is not very evidence-based. And on the other hand, is also counterintuitive. If recurrence is high, you would expect that many are taken away from the Kaplan-Meier. So high recurrence rate may explain why follow-up is not complete. Because all those with the recurrence are taken out and the curve become leaner and leaner. So might well be. How likely are the outcomes over time? Can we tell anything about recurrences? Do they happen early, late, or when? How do you look for this information in the study?
Kaplan-Meier.
Kaplan-Meier. How's the Kaplan-Meier curve is? Steep, flat,
Steep and flat.
more steep than flat. Let's see. So our group is the one continuous. What you can say is that after 12 months, there are very few recurrences, so it's flat. Which means most of the recurrences, they happen in the initial period. So, while for the other two, that for the myopericarditis and the, whatever was the other one, perimyocarditis, it seems more constant over time. But for pericarditis, it seems that in 1 year you get most of them. Actually, the bigger step is 6 months. Most of the recurrences are 6 months. Does this matches your clinical experience? Would you expect recurrences to be early for pericarditis? Or in pediatrics you don't see a lot.
I don't think we have registry here.
Yeah,
We don't.
but in general, at least in my experience, is pretty early. If it happened to recur, it's likely to be soon. Let's see what we have here. Most episode during the first year. And then, of course, it says no death, 30% recurrence, tamponade 2%, constrictive less than 1. Okay, is this what we were looking for? Yeah, more or less is this one. How precise are the estimate of likelihood? Can you tell? So what you need for the confidence interval? Are there confidence interval? No confidence interval. How you would call these 30%? What is 30%? Is a prevalence, is an incidence, is a rate? What is? Is an incidence, right? Is a 30% incidence over 1 year. Now, if you know, they didn't report, but if you know that 30% had a recurrence, Do you need, what do you need to calculate a confidence interval around 30%? You need just the denominator. So if you know that 30 at an event out of 346, and you go on internet and you search for confidence interval of, what is this? A proportion. Confidence interval of a proportion. You find a ton of places where you put in the two numbers and you get a confidence interval. So if you really want to know it, it's not a problem. It's not there, but this is easy. It's not like the confidence interval of a difference or the confidence interval of a relative risk where you need to put in a lot of numbers. The confidence interval of a incidence or the confidence interval of a prevalence is just a proportion, and you just need to put these two numbers into a calculator and you can calculate the confidence interval. So if you are really interested, you can do it. How do you expect this confidence to be? This is a 10% calculated out of 300 patients. You would expect more in the, I don't know, 28, 32 or something in the 15, 45. 1545. Everyone agrees with him? So you think that this is a small study to give you a narrow confidence interval? How many patients you think you would need to see with a 10% rate to find an interval of this size? 1,000? 3,000?
3-digit, 4-digit.
4-digit, 10,000. Maybe no, you don't. Maybe not 10,000, but for sure, with 300 is more likely we are here. Here we would possibly need at least a couple of thousand patients. It's very rule of thumb, but here I would not expect a very narrow confidence interval. If you are curious, you Google up confidence interval for a proportion, you put the number in, we can do it if we save time. Okay, so there are no confidence interval, but we could calculate them. Were these patients similar to the patient we saw? What do you think? Any suggestion? If not similar, what's the difference?
The management is somewhat similar.
Okay.
Almost all patients receive either aspirin or non-steroid, and our patients receive ibuprofen.
Okay.
Some study patient characteristics, there's no breakdown for patient who are already on immunosuppressed or no illness study. It's not updated for patient characteristics.
Okay, so that's one main difference. Our patient has rheumatoid arthritis and is on immune suppressant. Anything else? And then we'll decide if that's important or not.
There's no exclusion or inclusion criteria. Let's see.
No inclusion-exclusion criteria. So I calculated the confidence interval in the meantime, and they are in between 25, 38. So we are at this level of precision. So the patient is not exactly matching. Management is the same. And they raise the issue of colchicine, that for us is not a problem. So, yeah, very similar. Was the follow-up sufficiently long? What do you think? Was anywhere between 6 months and 36 months? So, yeah. On average was, 66. So, do you think is enough? What you base your judgment on?
An expert in the field, maybe.
Expert in the field, but looking at what you have available? The Kaplan-Meier. So after 6 months, few events. After 12 months, no events. So why continuing? They continued enough to say if there's anything, it's very, very rare. So yes, it's long enough. So, yeah, they say more or less the same. 3 years of follow-up in 100 patients seems sufficient. Recurrence were early, so of course you cannot exclude that there's something that happened later, but if that's the case, it's not really common. So sufficiently long, yes. Can I use this result in my practice?
Prognostic studies.
Yeah, no, okay. So to counsel patient. Would you feel confident now that what he was saying to the patient in the beginning, 1% mortality, maybe even less, and 30% recurrence rate? Yes, you can add if recurrence will be soon, so be prepared, is in the next 6 months or 1 year. Yes, I think you can use them in practice. Yeah, the study was mostly about comparing different subtypes, but that's not our problem. We want just to tell this lady how will be likely her course. So very likely, yes, we got useful information. How would you communicate this information to the patient? What would you tell?
From the data we have, these are the results.
So, I'm gonna die?
Less likely.
Less likely.
But there's a chance of recurrence.
Chance of recurrence. How big is that chance?
1 in 3.
1 in 3. Okay. Oh, I thought there was an. He's not in the slide, but I think it's another assignment. But I think that that's the way to go. And if she asks you, how sure are you about these numbers? It's unlikely for a patient to ask you, are sure you are you, but you may want to add that information. How sure are you?
How much did you get the confidence interval?
25 to 38.
Quite confident. I mean,
Yeah, so how would you communicate your confidence?
if we do it on 100 patients,
Yes.
55% of the time we'll get from this range.
Right. So possibly the way I would phrase it would be is a common condition, but there are not many studies that have followed patients for long enough. You have told this patient that you would have gone and done your homework. So say I found a pretty large one where they were able to follow about 100 patients for about 5 years, and 1 in 3 had a recurrence in the first year. So it's not hundreds of thousands of patients, but it's a sizable cohort. It's a common disease, but there are not a lot of studies, and I don't expect it will be different for you. More or less, you communicate risk to patient in a very lay, direct way. That's it. We are in advance. We are ahead of time, so we can either take a walk or rest. Or do you have any extra question or any comment or concern on this paper or on anything else you have been learning these days that you want to discuss or comment upon? Is this kind of reasoning on literature and evidence something that you feel will affect your practice or not? You think that this might help you in? It's really a true question, because if I look at my way of practicing, I do a lot of access to evidence, and I think that you provide a better service if you know what you are talking about. I wouldn't say always, but very often provide prognostic information to patients. I think that they want to know. And I think that this is it's a feasible way. You can't read a paper for each case, because that really would be too much. But there are common types of patients we see. At least for those, it's good to have some evidence behind. So, are you already doing this? So, are you learning something in this course? Yeah. Do you find this, I mean, you have your feedback to provide, so that's completely there. And if you can suggest what to change, my experience, I'm a bit external to this course because I didn't get to design the units Gordon Guyatt did with FAD, and I'm not based here. So I'm in a sweet position where I'm not really biased, and I'm not speaking for myself, but I saw that the feedback received last year was used to change the unit. So if you feel that there is anything that is not appropriate, is case is too rare, or is not something you see in practice, or some of the reasoning is not correct, make it in your comments, and you will help improving the material for the next group, assuming there's a next group. I don't know. Seems that they are planning for the 7th or whatever it is. Do you think that this way of working in groups is better than just being in the main room? Yeah. Okay. Anything else? If not, you have a bit of time for stretching legs, or you may read the paper for tomorrow's assignment, or check on your patient, or do whatever you want. Yeah, that's the end of it.
Thank you.
Good. Do you mind if I get back my paper? Yes, because I'm not going to reprint it, so I'll keep it. Welcome.
Dr. Zippi, in your lecture yesterday, you said your department, they have